Good afternoon, or maybe good early evening. I'm Jorge Delva. I'm the Dean of the School of Social Work. I want to welcome all of you to tonight's event. It's such a treat to have Dr. Bassett here. I'm also the Director of the Center for Innovation in Social Work and Health. That is one of the centers sponsoring tonight's event. And thank you for being here despite the game out there. I think it must have, has it ended yet? Do we know the score?
7-3 Red Sox.
Yes.
Can't be.
Thank you, thank you. I want to extend a very special welcome and thank you to Hubie and Katie Jones, pardon my accent. Thank you so much for your leadership and partnership. You're a person that I look after. I look forward to being a leader such as yourself. We're also fortunate to have our former dean, Gail Steketee, here present. Thank you. Someone I'm also looking forward to learning from and building on what both of you have built as part of the School of Social Work. The Hubie Jones Lecture on Urban Health is an annual symposium that addresses vexing health issues. The series was established by an anonymous donor to honor Hubie's vision. Over the last 6 years, we have featured leaders such as Paul Farmer and Adewale Troutman, who work on the intersection of health and social justice. The lecture is hosted by the Center for Innovation in Social Work and Health here at BU School of Social Work, and it's a center that's focused on connecting research, practice, and policy, and education to make an impact on the lives of some of the most vulnerable populations in society. Tonight, we're thrilled to have Dr. Mary Travis Bassett as our Hubie Jones Lecture speaker. I can think of no one better who embodies the vision of the Hubie Jones Lecture series than Dr. Bassett. She brings more than 30 years of experience as a champion of public health from Roxbury, Massachusetts and Harlem, New York, to Zimbabwe, Africa. Dr. Bassett has been keenly focused on how race, equity, and social justice, or lack thereof, affects the health of underserved communities. We're lucky to have you here in Boston, well, Cambridge, Boston, across the river, Boston, thank you. She's currently the director of the FXB Center for Health and Human Rights at Harvard University, as well as the FXB Professor of the Practice of Health and Human Rights at Harvard's T.H. Chan School of Public Health. Prior to Harvard, as many of you know, she served for 4 years as Commissioner of Health for New York City, where she led with an explicit racial equity lens. We're so grateful to have you here. Thank you again. Please welcome Dr. Mary Bassett.
Thank you very much, and good evening, everyone. It's a real pleasure to be here. When I was talking to the team at the Harvard FXB Center for Health and Human Rights, they pointed out that Hubie Jones was once the Dean of Social Work here at the School of Social Work at BU, but he's now the Dean of Social Justice for the whole of Boston. So what a pleasure to be able to address you this evening. And as it happened, I just recently saw Paul Farmer, who still speaks of you, sir. So I'm going to be talking about the long and deep history, including history from Boston, in part because I consider Hubie a son of Boston. I'm sure they claim you, but I actually found out that you're from New York like me. So, but you by now are a son of Boston. And I'm going to be talking about, let me see if I can get these to advance. Yes. I'm going to be talking about, and these days and these times, I find that I think about history a great deal. We should all be thinking about history a great deal. And I'm going to try and weave into it some of the history, the very proud history of Black Boston, and then focus on W.E.B. Du Bois, who was a titan of intellectual thought for the 20th century, I want you to note that I don't call him a black intellectual. He was a titan of all thought, as well as being a black intellectual. And the enduring imprint of the whole system of racial hierarchy, then the racist thinking and practice that it has spawned, advanced by an ideology that remains with us today of white supremacy, and the importance of acknowledging and understanding this history in our unending goal of achieving healthy lives for everyone among us. It's really impossible not to be worried about the world in which we live. I mean, not to be worried about the planet. Every year we are seeing an escalation in these horrendous weather events, floods, fires, hurricanes, cyclones, and these are escalating. And coming with them are news about the health of our nation that really should be a source of worry to us all. Last year, in 2018, the Centers for Disease Control and Prevention, that's our principal public health agency, announced that for the third year in a row, overall life expectancy in the United States has declined. Now, this doesn't happen very often. It happened in the Soviet Union before the collapse of the Soviet Union. It happened in Africa with the massive AIDS crisis, and it's happening in our nation. Additionally, the United States has the unhappy distinction of having rising maternal mortality. We are the only wealthy nation that has maternal mortality rates that are rising. And even closer to home in Massachusetts, we all know, I assume that you know, that one of the contributors to declining life expectancy is the opioid epidemic and the crisis in overdose mortality. And Massachusetts has sort of been a leader in the country in taking concerted action, but when they delve deeper into their data, and the most recent data are from 2017, they saw that the bending the curve, of which we're all so proud, and Massachusetts is one of the few states in the nation that's accomplished that, doesn't apply to all groups. And in particular, there's a continued increase in fatal overdoses among people of African descent in Boston, and the worst overdose rates are among black men. So I can't also let 2019 go by without reminding us all that it marks 400 years since the first enslaved African was brought to Jamestown in Virginia. That's the cover of a book that I read as a high school student. Maybe Mr. Jones is old enough with me to remember it. How many of you remember this book? Oh, a handful. And it's even before the Mayflower, there were enslaved Africans in what became the United States. And it's important for us to remember how many years it's been, 4 centuries since that date. And the deans of the schools of public health around the country have agreed that in October we will be marking this 400 years. And it reflects the impact of the transatlantic slave trade. If you aren't familiar with this book, you should be. It's an atlas of the transatlantic slave trade. In all, there were 12.5 million people taken out of Africa and brought across the Atlantic. You'll see from this map here that there was a slave trade that went to Asia and the Middle East, but the bulk of that slave trade was to the Americas. There was a very high mortality rate, with nearly 2 million people losing their lives. And of those, I hope all of you are watching closely enough to see how surprisingly slender the arrow is to North America. 388,000 Africans were brought to North America, and out of that, some 10,000 to Boston. But the bulk of the African population was brought to South America, particularly Brazil. and the fact that the United States once had the distinction of having the largest population after Brazil of African descent has to do with the particular rules about race classification that were adopted in the United States, in particular the one-drop rule. Now, Massachusetts had people who were enslaved. Many of us think of the legacy of slavery in this country as being limited to the American South, but it's nearly as old in Massachusetts as it is in Virginia. In 1638 was the first time enslaved Africans were documented in Massachusetts. And in the early 18th century, most black residents in this city were enslaved. But in 1783, not long after the War of Independence, the Supreme Court of Massachusetts declared that slavery was inconsistent, quote, our own conduct and the Constitution. So by 1790, there were no longer any enslaved persons listed in Massachusetts. I want to take a moment to just reflect on the importance of the free black population of Boston. Now, this is a population that was focused on ending slavery, and it may not seem like that has a direct relationship to health, but it does. It was very bad for a person's life chances and their health to be enslaved. And Boston, although it has still to this day, and in the years before the end of the Civil War, had a very, very small population of African descent. It really punched above its weight in terms of actions to support the abolitionist movement. By organizing itself into federations, the Massachusetts General Colored Association was organized in advance of the abolitionists that many of you may have heard of. William Lloyd Garrison worked in Boston, was an outspoken voice for the abolition of slavery. But the Massachusetts General Colored Association was established several years before, and he himself acknowledged that without the support of the free black population, without their subscriptions to his newspaper, Liberation, he would not have survived as a voice arguing against the ongoing enslavement of Africans in the United States. And of course, Boston was also a place where there was, where there were more radical voices. And David Walker's appeal, David Walker lived right here in Boston. All of you have probably heard of Crispus Attucks. All of us learn about his sacrifice, one of the people in the early resistance to the British colonialists. Crispus Attucks lost his life in the Boston Massacre. There's no existing picture of David Walker, but we should all remember him because he said that we should resist slavery by any means necessary, including a call for the enslaved to rise up against their slave masters. And then there are other, and probably many others, but I thought you should see some of them because Crispus Attucks is not the only black Bostonian that you should remember. William Cooper Nell, who was a prominent figure here in Boston during the 19th century, played a very prominent role in advocating against school segregation and segregation in public facilities. The same kind of arguments that occurred during my youth happened in the 19th century. There were people who felt that there was a gradual path to equality. There were people who advocated violence and people who argued against it. This is within the black community. There were people who felt that the vote was a central thing to fight for. And there were lots of debates about how to work with white allies and the way in which equality could be found within alliances with progressive whites in Boston. But Boston and Massachusetts as a whole were really advanced as compared to the nation. By the 1840s, Boston had desegregated its streetcars. You may remember that it was the segregation of the railways that led to the famous Plessy versus Ferguson decision in which a black man attempted to ride in a white car, and this was a decision made at the Supreme Court. Early on, there was an end to the ban on interracial marriage. My father is from Virginia. He married my mother from New Jersey, a white woman, and their marriage was illegal in the state of Virginia until 1967. So Massachusetts ended the ban on interracial marriage in the early 1700s. And they also really fought against the Fugitive Slave Act, which was really a way to threaten the free black population. In 1855, the state legislature of Boston ended school segregation. And this is important because it was an example where legislative action took over where a challenge in the courts failed. A child, I think her name was Julia Roberts, well, it was her parents, but they sued the city of Boston, and it was the Boston court that used for the first time the language of separate but equal, one that was echoed in Plessy versus Ferguson and stood for the United States at a federal level until 1954. So it was a further century until our nation as a whole had abolished school segregation. Now, the way to divide up the years that followed were first, of course, the Civil War, then 1865 to 1875 was the period called Reconstruction. And this is a period these days getting a great deal of attention. You may know that Skip Gates has recently done a whole series on PBS, written a book for adults and for children. And this period of Reconstruction was a bright light and a period of promise in this country, in which the vote was really captured by the newly freed population. And unbelievably, South Carolina, which was the first country to secede, and remains an emblem of white supremacy to this day, had a majority black legislature during the Reconstruction period. And then began the period of the end of Reconstruction and the resurgence of white supremacy. And before I finish my little reprise of history here, I have to mention William Monroe Trotter, who was an incredible man, a contemporary of another very prominent black intellectual. He really sacrificed his life to civil rights and activism. He was a graduate of Harvard. He was a newspaperman, and he was a leader of the critique of Booker T. Washington, who really epitomized the accommodationist view, and famously said that in all things social, we should be as separate as the fingers of a hand, and in economic advancement, we should work together. He also incredibly gave as good as he got when he had a conversation with Woodrow Wilson at the White House. I wish I could have been there. Woodrow Wilson said, "I would rather not talk to you anymore. You're being very impudent." And he, of course, led Boston in seeking to ban Birth of a Nation. But I'm going to move now, and I will be talking about health, by the way, to focus on DuBois. DuBois was just an incredible man. 2018 represented 150 years since his birth. He was born right after the end of the Civil War, and he died on the eve of the March on Washington. He lived a very long and fulfilled life. He actually died in Ghana. He had an elite education. He was the first Harvard PhD. He went on from a PhD at Harvard to studying sociology in Berlin. He wrote a number of important works which stand up to this day on a whole variety of topics. And I would say that he began as somebody deeply committed to the idea that we could study society the way doctors and scientists study the human body, that he was a real supporter of the idea that sociology was a science that was just as rigorous as any kind of conventional biological or physical science. And he talked about it this way. He said that the goal of, and the emblematic example of this was his treatise on the Philadelphia Negro, which he published right at the end of the 19th century. He had just taken a job at Atlanta University, starting a new department in which he was going to lead the development of sociology as a science. And he got funded to do this study of the Philadelphia Negro. And he described it as a careful search for truth conducted as thoroughly, broadly, and honestly as material resources and mental equipment allow. And he focused it on one area, the 7th Ward, and he had one research assistant. Those of you who do research in the audience will, and they collected 5,000 surveys and collated them themselves. And the survey covered a whole range of topics, from the population to all kinds of information about the lives of the people in the 7th Ward. And he ended up publishing it. It's over 500 pages. And he really wanted to go deep into understanding the conditions of the people he was studying. These were the kinds of questions that he asked. What is the real condition of this group of human beings? Of whom is it composed? What are the subgroups and the classes? And further, that the complete study must not confine itself to the group, but also notice the environment, the physical environment of city sections and houses, and the far mightier social environment. So this was a public health study. And he went on to publish reams and reams of data. You'll hear in a little bit why it was important that he demonstrated that between 1820 and 1896, the mortality measured in these neighborhoods declined. That's a reasonably short period of time in which a 70% decline in Black mortality was documented. And further, he published these charts. I don't know if you can make it out here, or if I can aim this at the screen. Probably not. Let me see if I can do it with a pointer. Does this show up for all of you? So you can see that the lowest mortality rate was in this area here, the 22nd Ward, and the highest was in the 5th Ward. So these were all mortality rates of Blacks, and he wanted to show that it varied. It wasn't stable across every neighborhood. It ranged from pretty low to pretty high. And he also compared the Black to the white mortality rate and showed that for every age group, but particularly at the beginning and the end of life, Black mortality was much higher than white mortality. And he went back time and time again to the focus on the environment, and noting that the highest mortality rates were found in the worst living conditions, and that the lowest mortality rate was found in the place with the best living conditions. So this was an important challenge at the time to race science, which was making the case that there was something inherently inferior about Black people that led to their high mortality rates. You couldn't make that case if you were able to show it was connected to variations in the environment. And he noted, and I think that this was prescient, that tuberculosis, that's at the time was called consumption, must be remembered that Negroes are not the first people, because this was a leading cause of death in the Philadelphia Negro. And he points out that Negroes were not the first people who have been claimed as its peculiar victims. The Irish were once thought to be doomed by that disease, but that was when Irishmen were unpopular. So he noted that there are that racialized classifications vary over time, and he most importantly made a statement about the variability of black mortality according to living conditions. And he did it very empirically. Now, in 1900, oh good, these show better to you than they do to me on this screen. He went to Paris as part of the Paris Exposition. And these are diagrams that were handwritten, hand-colored, and I'm just going to flip through them for you. He did them with his students at Atlanta University. They worked very, very hard on this because they had been given permission to have a whole exhibition devoted to the American Negro. And this is, they collected information on, on income and expenditure. This was of 150 Negro families, land ownership, the distribution of the black population in the United States. This I found really incredible. He looked at the age distribution of Georgia Negroes and he compared them to France. Now, I can't tell you how impudent that would have been considered by many sociologists who were white in the United States. The idea that you would compare the black population to a European population was pretty incredible. And then he, people tell me that these should be considered the first infographics, but I'm not so sure. Look at this. I mean, I really think that they were showing the modernism of the black population. This is one generation out of slavery, and they knew about this, and this, and this. So these were, they're just gorgeous, these graphics. They're now available in an atlas. But the next thing that he published was something entirely different. It was The Souls of Black Folk, which is claimed by sociologists, by public health people, by philosophers. He published it a couple of years after the Paris Exposition, and it's a totally different type of book than the atlases of beautiful graphics or the many tables and charts and graphs that appeared in the Philadelphia Negro just 4 or 5 years earlier. This was a lyrical tribute to the meaning of blackness in the United States. It was often biographical, his own story. At the beginning of every chapter were music bars with no words, just the music, from Negro spirituals, which at the time were barely considered music by the majority population. And he, in this, evoked the famous quote with which many of you may be familiar, that the challenge of the 20th century, or rather the problem. I guess all of us have been trained to never use the word problem. But back then he called a problem, and it was a problem of the 20th century was the problem of the color line. A remark that I would argue to you still holds to this day. He talked about the veil that separates people of color from others, the notion of double consciousness, which is the way in which you always perceive, a person of color always perceives themselves both as who they are and as how other people see them. He also evoked in this book the notion of the talented tenth, controversially. But it was a completely different type of book. And to my mind, it really represented the transition of DuBois from the idea that scientific study alone could lead to liberation, and the idea that a detached enumerative, sort of neutral science that he started out committed to gave way to the notion that we must be passionately engaged with the fight for equality. Now, this had to do with what was going on around him. You remember that he was born right after the abolition of slavery with the 13th Amendment. Then, as you all may know, the United States was very eager to welcome the Confederate States back into the Union. All they had to do was declare that they were now loyal, and they were able to now be considered bygones were bygones. And a whole raft of laws were passed that came as close to reinstituting slavery as you could get. They began the black codes, contract labor, these sundown towns where people who couldn't show that they had a job would be arrested, the auctioning of contract labor and the reintroduction of the auction block, the reintroduction of whipping as a punishment. The North sort of gathered itself up and regained enough support to pass the 14th Amendment, and which established citizenship and the notion of equal protection, so important to this day, and then the 15th Amendment, which established the right to vote. But those were put on the books, and Reconstruction ended, and Plessy versus Ferguson became the law of the land. And this is when DuBois is beginning his intellectual life, when although the formal enslavement of Africans had ended, the process of criminalizing black people continued, and the Jim Crow period was well underway with the frequent use of lynchings. At the time that he was writing Souls of Black Folk, lynchings were happening regularly in the South. And this continued until the 1960s, which was the time when some people describe it as the second Reconstruction. Now, of course, we've seen a pushback, and we're seeing its continued pushback to this period. I'm a product of the 1960s. I got to go to Radcliffe College and Columbia University because of the efforts of many who fought to make that possible. And of course, Du Bois would have been well aware that all these statistics that he was trotting out were not going to win the day, because at the same time that he was publishing the Philadelphia Negro and showing how mortality rates had gone down by 80% in a period of 70 years. This gentleman, Frederick Hoffman, was using prudential life insurance data and the 1890 census to make the case that high mortality rates among blacks was evidence of inferiority. In fact, he predicted that the whole black population would die out. So the finding of high mortality rates, which I continue to use as evidence of unequal access to healthy life, was used by Hoffman to make the case that blacks were intrinsically inferior. And he wasn't the only one. I'm at a school of social work. I'm sure you're all very familiar with Jane Addams. We all have a lot of respect for her as the founder of social work. But she also had a lot of racist ideas. She believed that for the black population, that the possibility of benefiting from settlement houses was limited, whereas the European population had a legacy of civilization and had been disrupted by migration and the experience of being a dislocated immigrant. And among them, civilization, she believed, would reassert itself. She didn't think that this was true for people. And she even published this in the NAACP Crisis magazine. She wrote this and published it. So there were many people who looked at the data of poor health status among people of African descent and decided that this was proof of the inferiority of people of African descent. So I've been trying to take you on a quick whirlwind through the arc of history. And this is a graphic that was done actually by a group in Baltimore. But I'm going to show you another slide that shows my annotation of it. But broadly, it does make clear, I think, that in the many years, 400 years, the period in which there were legal rights is a pretty short period. That's the green there. But, you know, we can divide up that green. 1954, some people take to be the end of, you know, the beginning of desegregation. Other people would make that the Civil Rights Act. But of course, in 1980 came Reagan and the beginning of policies that drove mass incarceration. So, you know, I'm not sure that should be all green. And that's why I think we have to talk about racism. Now, racism is not just not liking people because of their color. It's having the power to do something about that and having institutional power. And I find this taxonomy of racism to be pretty useful. You see them here. Internalized racism is when an individual internalizes beliefs about his or her own inferiority. I was speaking, people tell me that you're called Hubie, so I was speaking with Hubie before the lecture, and I told him I would be showing him a picture from the famous doll experiment done by Kenneth and Mamie Clark. And this little boy is being asked to pick the doll that he likes. He's being shown, as you can see, a brown doll and a white doll. And most children pick the white doll. And this was repeated by a New York City high school student just 10 or 15 years ago. And the exact same thing was found. When a child is told, pick the nice doll, the smart doll, the pretty doll, a brown child, most of the time, reaches for the white doll. So even at these young ages, these children have internalized the idea of what good is, and that's what segregation does, they argued before the Supreme Court. This doll experiment was included. Interpersonal racism is what we usually think about. This is one person being prejudiced towards another. This has now gotten a lot of attention because of the concept of implicit bias, that we may act towards people in a way that we're not even aware of because we have sets of beliefs about inferiority and superiority based on race that we've imbibed from our society. And institutional racism is racism that occurs based on institutions. So this is a picture of a child being led, I think this was in New Orleans, into a public school in New Orleans to desegregate the school. Questions around employment, around college admissions, for example. This would fall under the category of institutional racism. And these days, we also talk about another form of racism, which I think is worth me taking a moment to talk about, structural racism. This is from an article that, while at the New York City Health Department, the first author is actually a young woman named Zinzi Bailey. I think her reference is there, but I think the editors of this series on inequality in America were a little surprised that a health department wanted to do a whole article on structural racism. I think they thought we would just want to do something on doctors being prejudiced towards their patients or something. But I think it's a really important idea. And so I'm just going to take a moment to go over the definition that we developed in this paper. And that is that it involves interconnected institutions whose linkages are historically rooted and culturally reinforced. It refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources, which together affect the adverse risk of health outcomes. So it's not just one set of private prejudices. It's not just one institution. It's not even just institutions alone. It's reflected in the culture, in the way we represent ourselves. Structural racism is foundational and works through multiple pathways to create risks for health. It's not a single thing, but it's deeply embedded in our history, as I hope I've successfully shown you, and up to our present day. And it does include things like maladaptive coping behaviors. That means, you know, drug use and risk-taking, violence. Stereotype threats is an interesting and, I believe, established experience in which people faced with the notion that they're not going to do well at something because they're believed to be not good at it on a group basis. And in turn, just like it happens not just by race, but other forms of race, of group identity, by gender, by sexual orientation. Somebody tells you, you know, girls aren't good at math. So when faced with a math problem, you feel threatened by the concept that you're going to fail. But structural racism really underlies and forms a platform by which all these other forms of racism express themselves, that then work through these multiple pathways and result in inequalities in health. I'm going to use mortality, premature mortality, as a sort of principal adverse outcome. Obviously, people die of all sorts of things, but when people die too young, and in this graph it's before the age of 65, I think we can agree that that was an avoidable death by and large, that people shouldn't die that young. And this is a graph created by Nancy Krieger and colleagues at the School of Public Health at Harvard, based on census data and vital registration. The first thing I always like to point out is I want people to see that mortality has fallen for everybody. So if I'm depressing all of you, I want you to remember that mortality is improving. We should all be very glad that we don't live back here in 1960, you know, when when mortality rates were higher. Down here are non-whites, and down here are whites, and these solid lines are non-whites. The reason it's divided by non-white and white is because at the beginning of the census, there were no other groups considered. Everybody was considered either white or non-white. So to make it consistent over the life of the census, it goes like that. So I could spend a lot of time talking about this graph. The first thing to note is that the slopes, so these are non-whites. Most non-whites are people of African descent, but it includes all people who aren't classified as white. And what you can see, oh, I'm sorry, let me go back again, is that it's not till here in the mid-1980s. These are income quintiles by census tract. So this is the highest income quintile of non-whites, and this is the highest income quintile of whites here. And it isn't until the mid-1980s that the highest income quintile of non-whites, yes?
I'm sorry, Mary, could you tell us what color the lines are that you're referring to?
Okay, the pink lines are the highest income quintile. the blue is the second quintile. It moves around a bit. Sorry, the fourth quintile. And the red one is the fifth quintile. So here, this shows in the mid-1980s that, and when I distribute the slides, I'll get the key for you and add it to the slide. In the mid-1980s, that's when the highest income group of non-whites became equal to the premature mortality rate of the poorest white group. So until then, regardless of your income classification for non-whites, across all groups, you had higher premature mortality rate than all whites. Are you with me on this? Yeah. Okay. I often ask people to take a guess. The cut point 65 was used because it took a long time for stable rates of premature mortality using that cut point to be established. And life expectancy to hit 65. So I'm not going to get the exact years right, but white women reached a life expectancy of 65 in the 1940s. So did white men sometime in the 1940s, a little later. Black women reached a stable life expectancy of 65 in the mid-1950s. Anyone want to guess when black men reached a stable life expectancy? That means it never fell below 65 in the subsequent years. No, it has, but it was in the 1990s. So it was a full 40 years later. So, this, I think, it's very sobering data for us because it still shows the enduring impact of these racialized classifications on the likelihood that you'll live a long life. Despite the fact that mortality has gone down, another thing to notice is that it was much steeper in this period. And it's gotten flatter, right? And here, I can't show you, but look at the red line only. And between 1970 and 1980, it looks like it's going down at quite a clip. And it's now sort of flattened out. And so when you analyze it by time periods, there are real differences in inflection by what political party is in power. So this history is reflected in our cities. Massachusetts is one of the wealthiest states in the United States. It's also a very white state. It has really low rates of uninsured, which you should all be really proud of. And it has a really high life expectancy. But we all know that these averages don't tell the whole story. And this shows that the wealth of the state is all, decreases rapidly as you move west. These are more recent data. And the lighter the color, the wealthier the area. And it's not unusual that cities concentrate poverty, so that the poverty rate in Boston is twice the poverty rate in the state as a whole. And of course, this area of impoverishment in Boston has a direct relationship to the practice of redlining in Boston. I'm sure that all of you are familiar with redlining. These areas were considered hazardous, and it probably explains this observation, which I found truly shocking. This was done by the Federal Reserve Bank. It's a measure of wealth, not income, and it shows that the average household wealth, and these data were published in 2015, of whites in Boston was nearly $250,000, and blacks just $8. And the only explanation for that I can think of, wealth represents debt minus assets. Of course, people have credit card debt and so on. But the only thing that I can think of that really explains this is home ownership. And that, of course, is what redlining deprived the black population of access to. And this is an example of structural racism, which I was describing before to you, this is, 2 generations ago, that the redlining created the opportunity or not to have access to a mortgage, and it continues to underlie the huge wealth gap that exists, much bigger than the income gap in the United States and in your city. And this is why we can have transit maps that look like this. This was developed by your own School of Public Health, showing what happens when you go along the T-line. And I went to college here many years ago, but I know that I'm pretty sure Dudley Square used to be it was in Roxbury. Is it still? It's still there? Okay. It's no longer a train station, though. But you can see that the highest premature mortality rates remain in Roxbury, and you can, just a couple of stops away, you get these huge variations in the risk of premature death, reflecting still the impact of redlining. So I wanted to take a moment to show you why it's so important to think about race when we look at data. And am I running way over time by now? Yeah? I'm all right? Okay. I hope you can see this. This is the US life expectancy. And I want you to just notice that it started pulling away from our peer wealthy nations a while ago. So there's a lot of conversation now. I began my remarks by saying that US life expectancy is declining, but it didn't just happen overnight. First its increase started slowing, and then it started going down. And that began in around about the 1980s, early 1980s. And recently, this graph made it into the New York Times above the fold. That's important, showing how the mortality rates were going for U.S. whites in a certain age range, between 45 and 54. Astonishingly, this group has rising mortality rates, mostly because of suicide, liver disease, and drug overdose. And you can see, well, I'm criticizing them, and I was complimenting DuBois. They consider that their comparison group should be France, England, and Canada and other wealthy nations. And you can see that all these countries have declining mortality. But when I asked the team at the health department to redo this graph and look at blacks, you can see that despite this worrying line, and it is very worrying, that premature mortality rates, or black mortality rates in this age band, remain much higher for blacks than they are for whites. So that's really important to notice. Before we turn around and say that the people off track in this country are whites in middle age, we have to remember what's going on with blacks in that group. It's not like the problem of excess mortality has been solved. As you can see, it's still there, although mortality rates have narrowed. And that's not the way we want to see inequalities addressed. But I don't think that we should forget that the mortality rates remain much too high among African Americans. And I talked with the Princeton researchers, who include a Nobel laureate, about the way in which they framed these data. And they said this on the record, and they said it to me, that they didn't include the line on blacks because that wasn't what interested them. So additionally, we've seen something special happen with the opioid crisis. We've seen a surge in overdose deaths related to the prescribing practices of physicians and other prescribers, driven by the eager encouragement of the pharmaceutical industry. This opened opioid dependence to a new population. Unbelievably, doctors believed the message given to them by the pharmaceutical industry that when people had real pain, unlike those heroin addicts who are just pleasure-seeking, depraved individuals, when people have real pain, they don't become addicted. There was not a shred of biological evidence of this. These are addictive drugs, but people believed that they were giving pain to people who deserve to have their pain addressed, painkillers to people who deserve to have their pain addressed, people who had health insurance. And that was how the complexion of our opioid epidemic changed. And of course, with this, we've seen a new narrative that we need to give people help and not punishment, that we need to view their, now we're not supposed to even use the word addiction, it's substance use disorder, as an illness and not as a crime. I agree with this, but I think it applied also when the complexion of this epidemic was very different. And I pointed out to you in the beginning that we have this problem now, that while the tide has turned for many people with substance use disorders and opioid use disorders, it's not going in that direction for people of African descent. In New York City, the majority of overdose deaths are now among people of African descent in the Black and Latino population. And I want us all to be very mindful of what happens to the narrative as the complexion of this epidemic may shift. So I'd like to leave you, and I am wrapping up, with a simple way of testing whether or not we're confronting racist narratives in the work and the interpretation of data. If the argument is that the problem is people, either because they have some kind of genetic proclivity for illness and early death, or because their culture doesn't support healthy living, or they're ignorant, either one of those arguments places the problem with the people. Or, as DuBois argued way back at the beginning of the 20th century, is it the context, the neighborhood, the living conditions? And when we hear that the problem is being blamed on the people, we should always interrogate that as a racist idea. So finally, I hope I've given you the clear idea that it's really important to understand history, that I am in complete agreement with W.E.B. Du Bois, though, that data will never be enough to defeat racist ideas. We need data to understand where we've been, to tell where we are, but where we're going is always going to be a social question, one that's determined by values and not just data. Thank you. So we have, thank you. So we have time for some questions, and I'm happy to field your questions if you have any. And to get a drink of water. Wow. I feel like I should ask myself a question. I know that it's interesting. I think of social work as really having two main threads. So one of it, the concept of supporting individuals and the sort of psychosocial counseling part of social work. And the other part of it is really a community organizing framework. So I'm not surprised that I'm encountering an audience that really understands how important the social context is to everything about people's lives. Do you have a question here? Thank you.
Yes, so I was just struck when you said that the researchers said, oh, we didn't want to focus on other than white people's health because that's not what we were interested in. What is, when you look at the structural racism, what is the context for, like, when people get funding to do their research? Like, how do you trace, are people getting supported, or is there money going to their research Like, who makes those decisions about how that
Well, that's
gets
an
funded?
interesting
Because that, to
question. I
me,
mean, I think I haven't looked at it in a couple of years, but a couple of years ago, looking through what the NIH, which is the premier health funder, was funding. Wow, I mean, over and over again, you'll find genes, genetic, the word genes or genetic as a key word. The number of times that socioeconomic or race, ethnicity appears is a fraction of the amount of funding that's going to gene-related research. And I believe at the time that I looked at it, the word racism didn't appear at all.
thank you.
More of a comment than a question. I grew up or was a teenager in the rural South in the early 1950s. And a lot of the data that you present really resonates with me and my own experience. But my own experience also is that on the point between people and context, that my peers, excuse me, my peers in that period, when confronted with the idea of context, would inevitably bring it back to the people, that they're in poor housing or they live that way because, and then other qualifiers would follow.
Right. I think that's right. And it's supposed to be really a deeply held cultural value that we believe people make their own futures, and therefore that is not too far from where people sort themselves out in the social hierarchy as where they belong. That's a self-fulfilling, it's a circular argument. When people aren't allowed to progress, then where they are becomes normalized. Yeah. So I thank you for that comment.
Thank you very much for your remarks, and thank you very much for your work in New York City and your inspiration. I remember hearing you at APHA a few years ago talking about your experience as commissioner in New York and saying when you went to your colleagues and other cabinets and talked about health in all policies, you thought they wanted you to do them to do your job. But when you talk about equity in all policies, you really had a different impact in conversation.
Yes.
So thank you. That was inspiring and very important to some of our work. What are you doing at the FXB Center? What's it about? Where are you headed?
Good question. Well, the FXB Center, as you probably know, was established in the early 1990s by Jonathan Mann. And it was endowed and has as its goal promoting the idea that people have to have rights in order to have good health, and that people who are marginalized and deprived of their rights are not likely to have good health. I took over from a director who worked mainly in humanitarian crisis response to conflict zones or places that experienced weather disasters. That's good work, and it will continue. I'm very interested in adding additional work focusing on discrimination and state violence. The other part of my vision for the center is that we add to it the concept that the United States also has some human rights problems, and that we don't just view human rights as something that happens out there, but as something a perspective that we need to advance the health of our own population. I believe passionately that health is a human right. I was lucky enough in my young life as a doctor to have a mentor, and he was telling me not too long ago that he remembers that I showed up with my white jacket on and a button on my lapel that said, "Health is a human right." And that's what I wore when I went to see my first patient. So I think that holds just as true for the United States. I hope all of you have taken the Medicare for All. The idea of single-payer health insurance has had its first airing at a congressional hearing, and it was pretty moving to watch the testimony. So I'm hopeful that we can move FXB to engage with many of these issues, as well as continuing to engage with issues of displaced populations, populations on the move. So I moved to Boston in January, so stay tuned.
Hi, thank you so much. Appreciate especially your DuBois example. So helpful. Here's my question. How do you find yourself using data these days to, as you're making the equity argument, to, maybe people on the right, but people in the middle and just your general public, using data that shows, for example, that African American women who are highly educated and have all the social contexts that one would expect to have positive birth outcomes actually don't. And that prematurity, it's the racism argument.
Yes, that's
but
right.
I'm wondering, it's about context, but it's not just about social conditions. It's about racism.
Well, I hope, yes, I couldn't agree with you more.
Right. No, I'm repeating what you're saying. And my question is, how do you find yourself showing that, making that argument? With data, how do you demonstrate, with data about the impact of toxic stress and sources of racism in the human body? Or do you find through stories, examples of, in this case, African American women who are affluent, still experiencing the same? Does that make sense?
Yes, it does. I think what I encounter the most is people's sense that this has been going on this is sort of bred into the foundation of our country, which it is. This country was founded, the first 4 of our first 5 presidents were people who owned human beings. And so people feel like, we're not going to ever shake this. And that I really don't believe is true. So the experience that you're talking about, I think that this framework helps. It includes the notion of internalized racism, how people think about themselves. It includes interpersonal racism. We all heard the story of Serena Williams, who said, I think I've had a pulmonary embolus, and even a woman of her standing encountered dismissive behavior on the part of the healthcare workers who were there to take care of her. So it includes that. And then it includes structural issues, the whole thing about how healthy you are when you become pregnant. But I guess what gave me a lot of hope when I was at the health department, and I didn't share them this evening, was a whole series of stories about how people at the department began using a racial equity lens to apply to their work in really unexpected ways. So for example, the health department is responsible, has public health engineering department in New York City. I don't know if this is true of all health departments. And they're responsible for numbers of things. They check the radiation exposure of machines in hospitals. They check water quality. And they investigate swimming pool deaths. So it turns out that a black child is something like 8 times more likely to drown in a swimming pool than a white child. So the public health engineering people, and I really like them, but they're really nerds. I mean, they're not social justice pioneers types, really. They said, we ought to do something about this. They have to watch the videotapes. that may exist. So they started a summer program to teach kids to swim. And they said, you know, the Parks Department has a great program. It's first come, first serve. You know what happens when something's first come, first serve. Who gets to get that program? So we're doing it in neighborhoods. Turns out there's swimming pools in public high schools in New York that are not used in the summer months. Without me even knowing about this as commissioner, because I just went up there to talk with them about something else, and I saw these pictures of kids with swimming goggles on the walls. They got the schools to agree to let them use the pools, the Parks Department to provide the lifeguards. They went out and raised, you know, got donations of swimming clothes, and they had, when I left, they'd had 3,000 kids go through the program. So, you know, that is, to me, is an example of how people take on board the idea that they need to look at their data and then they need to do something about it. So, you know, I think that the really important thing for all of us is to remember how much better we are now than we were 150 years ago. For everybody, the risk of deaths has gone down enormously, that we have the capacity to make change, and that we just need to think about how to do it. The health department implemented implicit bias training for the entire senior leadership, and when I left, 1,000 of 6,000 employees had undergone training. So I hope, you know, this is the sort of thing that should continue. I hope it does continue. You know, you need to have, we really need to stick with the idea that we can advance. But we can't do it by not acknowledging the existence of racism. I think there's one last question, and then I think is that the last one? Okay, there's somebody there in the back. Thank you.
I think the last question kind of implied presenting this information to the white power structure, or as opposed to presenting this information to communities of color, which is a different narrative. As I work for the Boston Public Health Commission, we are doing this work. The population I work for is our adolescents. Presenting them statistics is always not quite a good idea, because there's a danger they'll be taken as prescriptive rather than descriptive.
Yeah.
And when they're forming their identities. So I just wonder how the narrative is presented to communities of color in a way that's not so bruising, in a way that is more innervating, and in a way of call to action.
I think what you're getting at is that people react to the sort of drumbeat of adverse health outcomes by feeling like we failed, we failed, we failed. And part of that is the deeply held belief that many of the frequent causes of illness and death are related to bad choices. So it's very important to reframe that. And part of that is with images and storytelling. I think you mentioned, mentioned that data alone aren't like that, may not work like that. So when we talk about eating fruits and vegetables, you know, let's talk about what kinds of foods are available in poor neighborhoods, what kind of foods are marketed, the fact that Black communities are specifically targeted and really a form of racial profiling with unhealthy foods. You know, we had a conversation about menthol, and there's a bill before the City Council in New York City to ban menthol cigarettes. That's been done in San Francisco. And it was really interesting testing out the ideas. I wanted this, like, you know, the cigarette industry wanted us Black people, because I was a Newport smoker as a teen, to smoke menthol. And so we should rise up against it because that's what corporations wanted us to do. That tested terribly. Nobody really wanted to hear that they'd been duped by corporations. So I agree with you that, that we need to be mindful of how we convey these ideas, that we have to also acknowledge the presence of assets, which I haven't done this evening, that the same neighborhoods that bear the excess burden of ill health gave us hip-hop, gave us jazz, gave us many of the things that we all value as part of the vibrancy of our culture. So your point's well taken. So I thank you. I think it's a nice way to end the evening. Thanks very much.
Just,
Yes. I don't know.
I wanted to thank you for what an intense, history-rich presentation. And yes, you presented a lot of data, very well informed by this larger context that dated back hundreds and hundreds of years. And that really resonated with me, and I'm sure with the audience. I want to thank you again very much for your
My
presentation.
pleasure.
Thank you.